with two buttons with one screw, one button construct. I would really like to thank and acknowledge the team at Quasar, as this project has taken us over 2 years to complete. And I would really like to acknowledge Zimmer Biomet for providing all the equipment in terms of the devices, which is the Zimmer toggle lock and the screw for the Latarjet fixation. So Latarjet is one of the most common procedures which is performed by sports physicians and shoulder surgeons worldwide. And we know that anterior inferior glenoid bone loss is a hallmark pathology for shoulder instability. I've been doing arthroscopic Latarjets now for around 5 years. And initially I was very happy just to be able to do the operation arthroscopically. And then as you go on with your experience and your learning curve, you start finding nuances within the procedure per se itself, which you would like to improve. So this is a case of glenoid bone loss, and this is the immediate post-op x-ray. And you'd be quite happy with that alpha angle and the positioning of the two screws. But then the patient comes back to you 1 year post-op, and he's asymptomatic, but you start noticing osteolysis of the graft. And this gentleman, unfortunately, was not asymptomatic. He started developing pain with external rotation, which in my head was pretty typical of the superior screw rubbing on the subscap and causing him pain. So I had to go and remove his top screw, and his pain improved quite significantly with this. Then the patient disappeared for 2 years. As with young people, they are a migrant population, but we were able to, then the patient represented to me 3 years down the track with signs of more posterior and inferior instability. He was quite solid anteriorly, but posterior inferiorly he had instability. Now I'll show you the CT scan in a minute, but I'll show you the arthroscopic findings of what the shoulder looked like when I went back in at the 3-year mark to assess his shoulder dysfunction. So this was the Latarjet, which is extra-articular. You can see I'm trying to dislocate the shoulder. The shoulder is end-located. He's got a posterior labral tear, which we'll demonstrate soon, but I could not reproduce any anterior instability in the shoulder, and he had a posterior labral tear which needed attention. But if we look at, so this is him 3 years post, but this is what his CT scan looked like at that time when I was scoping his shoulder. To my surprise, the graft had completely disappeared. And this is quite shocking for me. I've never had a patient with 100% graft resorption. So this brought about this concept to me further a few years ago, that are the constructs that we are creating with the two screw fixation really too rigid? And do we have long-term follow-ups with CT scans on these patients to analyze if they're actually undergoing stress shielding and if there is bone resorption? So I do believe that some degree of graft resorption and osteolysis is universal. Is it because of stress shielding? Is it because the graft is avascular and only the conjoint tendon or the tip of the graft is vascular? Or is it because of Wolff's law that the superior part of the graft is not loaded? Dr. Zhang from Beijing has published a really nice paper on this in 2015, where he's categorized the grade of osteolysis as grade 1, 2, and 3 based on the zones above the top screw, in between the screws, and below the screws. And he has noted his findings in this really cool paper. So we've published on the complications in Latarjet, and as most people know, that getting the graft in the right position is a big iatrogenic and intraoperative problem for all of us surgeons. Sometimes the patient anatomy doesn't allow you to get that alpha angle to less than 10 degrees. And in the long term, something which is a passion of mine is to figure out what's the deal with this osteolysis. Now, will two buttons work? I know Philippe is going to be presenting his experience on the two buttons, but to me, it doesn't really make biomechanical sense. Sorry, Philippe, for this. Just trying to be controversial here. And this is an example why. This is the testing we did, and this is at 0.0. And you can see that there's just no strength in the construct, even though this was tightened to over 100 newtons, both the buttons. But this is how the two buttons respond under loading immediately. So in 2018, I converted to the fact that if two buttons might not be ideal and two screws are too tight, what if we do something in between? What if I put a screw at the bottom for rotational stability and put a button on top to allow compression, but just enough so that I don't have osteolysis? And I thought this was a great idea. So luckily in 2018, then I went to the Japanese Orthopedic Association meeting and I met my good friend Yoshi, who, to my surprise, was presenting a similar paper at the Japanese Shoulder Society meeting, where he'd been doing one button on top and a screw at the bottom, and he presented his paper here with his early results. So much for coming up with a bright idea, or as Yoshi says, great minds think alike. So then we came up with this study where we wanted to check the biomechanical stability of the double screw versus double suture button versus screw button combination. We know that there's been studies which have been done on double screw and double button, but we wanted to investigate the third modality. We wanted to characterize the load to failure and characterize the displacement of the graft for each construct. We went to quite lengths to conduct the study in a very detailed scientific rigor. So we had cadaveric specimens. We CT scanned cadaveric specimens to determine their suitability. Then we built with these CT scans we used our anatomical concave surface area method to calculate the glenoid surface area very accurately. Then we potted these cadaveric scapulae, and we built custom jigs for each cadaveric scapulae. So we created 20% defects on the software and were able to build PSI jigs to create a perfect 20% bone loss, which was perpendicular to or parallel to the flat horizontal surface area. And then PSI guided Latarjets were performed by shoulder subspecialist surgeons. These scapulae were clearly potted to make sure that the glenoid was totally horizontal to the base for biomechanical loading, and the Latarjets were performed. The screws were tightened as we would normally tighten, and the Zimmer toggle locks or the toggle locks were tightened to 100 newtons of strength by a tensiometer, as popularized by Dr. Boileau. Followed by this, standard biomechanical testing and cyclical loading was undertaken for the specimens. While we were doing this, the Latarjet part and the glenoid surfaces were digitized using a digitizer into 4 zones to see translation of each part of the graft with respect to the glenoid. And an XY stage was used to ensure that we were parallel to the graft, and the apex of the load was aligned between all the constructs. Standard testing, biomechanical testing methods include a baseline ramp to 5 newtons, cyclical loading over 100 cycles from 50 to 150 newtons at 1 hertz and at 200 newton seconds. And a load to failure. Then we ramped the graft to load to failure in the end with 5 millimeter per second till the graft construct failed. A failure was notified if we had a graft fracture, if the screw was avulsed, or if we had a displacement of the coracoid fragment by more than 5 millimeters from T0. And these are our results. So double screw is considered the gold standard, and it failed at 604 Newton meters, which is what other studies and past studies have also demonstrated. Surprisingly, the double button only withstood a load of 128 newtons. But more importantly, you can see that the double screw failed at 105 seconds, whereas the double button failed immediately almost at 17 seconds. And the screw button was in between the two at 306 Newton meters. So if you can look at these two videos, you can see this is a time lapse of the same, where the double button fails or loses strength very quickly, whereas the screw button construct on the right, you can see that we are loading this graft now, cyclically loading the graft, and there is a dip at the construct, but there is no obvious failure initially. These are the results which show that the screw-screw construct, screw button and button-button construct, and all these values were statistically significant. When we looked at the gaps between the 4 digitized points, it was interesting that when we used a construct which had 2 of the similar devices, you had more of an oblique load going through because of the translation, whereas the the button screw had more of a horizontal load. But I would pay caution to this slide because the displacement here is less than a millimeter. So we're really trying to nitpick here, and I'm just reporting this because this is the true data which we found. So the discussion, we think that the screw button construct may be a viable option based on our biomechanical testing. However, this is limitation is that this is related to time 0. To understand bone union or osteolysis in the future, we need an FEA and a clinical study. I've been conducting a clinical study on a 2-year follow-up with 1 screw and 1 button now for 2 years. And this is a CT scan of a patient at the 2-year follow-up after an arthroscopic Latarjet with 1 button and 1 screw. And as you can see, there's very little graft resorption here. And I'm finding this more and more commonly with our patients now. And this study is still going on. So I think it'll take us at least another 2 years to be able to give clinical results and outcomes on this. But so far in our early 2-year mark, I would say in my practice, this is very reliable, and I haven't had to go back and remove a screw from the top part of the graft in the last 2 years. Thank you for your time.